Well, good morning. I'm Tim Sheehy, President of the MMAC, and welcome to the Business of Metro Milwaukee, a monthly webinar spotlighting the challenges and opportunities to growing the region's prosperity. We hope the insights from this program help you make better business decisions while providing information that helps you to shape the region's future. Today's program is sponsored by United Healthcare. MMAC has partnered with United Healthcare to make it easier to find a health plan that works for your employees and your bottom line. An MMAC affiliated broker can help you receive discounted rates on United Healthcare's level funded plan. You also have the option to add other United Healthcare plans to your employee benefit package, such as specialty plans and supplemental financial protection plans for groups with as few as 5 employees. So find out why 500 of your peer companies have signed up. Contact your MMAC broker or visit mmac.org to learn more. So for today's program, how will COVID end? That's the question posted on the cover of the most recent issue of Time magazine. And a similar headline ran in the New York Times. The answer to this question is not only pertinent to healthcare, but to considerations for staffing, supply chain management, business travel, and our overall economy. So as caseloads come down, mask mandates come off, and the pandemic looks to become an endemic, what's next and what kind of lingering impact will be left from COVID? Joining us today to share some insights on those thoughts and more are Dr. John Raymond, MCW President and CEO, Dr. Julie Biller, MCW Professor and a specialist in pulmonary medicine and director of the Froedtert and Medical College of Wisconsin post-COVID multi-specialty clinic. Also joining us is Dr. John Lehrmann, the Charles E. Kubly Chair of Psychiatry and Behavioral Medicine and a professor in the Medical College of Wisconsin Department of Psychiatry, and Behavioral Medicine. So if you've got questions, please add them to the Q&A or to the chat function, and we'll start with Dr. Raymond.
Good morning, Tim, and thank you for the introduction. Really pleased to be here, and we'll try to run through this quickly. I'm going to talk about COVID numbers and just a little bit of a sneak peek about what might be happening in the weeks ahead. The next slide, please. Thank you, Chris. These numbers remain high, but the trends are very, very favorable for us. So we are on the downturn from the Omicron spike. Our 7-day average is over 3,000, as you can see at the upper left, but trending favorably and rapidly favorably. The positivity by percent by test also is trending favorably, but remains high. We want that positivity rate to be under 5%. On the other hand, the reproductive number is looking good, both in Milwaukee and in Wisconsin, significantly under 1 and trending favorably. That is indicative of a shrinking pandemic trajectory. And if you look on the bottom left, the 7-day average for the numbers in Milwaukee also is trending favorably and is about what we would expect compared to the rest of the state. So mostly good news here, although case burdens are still high. Next slide, please. Our deaths are trending downward, which is good news. They had been trending upward for the last month, and we did expect them to eventually start to go back down about 3 weeks after the peak of Omicron, and we're at about 3 weeks right now. So those deaths are going down. They were in the mid-30s, and we want them to ideally go back to where they were last summer, which was low single digits for the entire week. We still have a lot of hospitalizations, over 1,200, but less than half of what we were experiencing just 3 weeks ago when we peaked with Omicron. Our ICU census also remains high, but is about half of the peak that we saw a few weeks ago. And I want to point out that our ICUs at our hospitals are still very, very full. We still have a lot of non-COVID disease that needs to be taken care of in the routine course of managing patients. We have pent-up demand for deferred and delayed care. And we have been running at 90% plus, both in terms of ICUs and hospital bed occupancy now for 6 months. And we're two years into a pandemic where we've been running high, and our staff are tired, and many of them have been sidelined in the last few weeks, either with COVID-19 or with a documented exposure. So they were quarantining for their 5-day period of time. So this is still a challenge for us. And the trends in the ICUs in HERC 7, which is southeastern Wisconsin, are tracking just along with the rest of the state. So still a lot of cases, but trending favorably. Next slide, please. These pictures are captured from the Wisconsin DHS website yesterday, and you can see with the red circles, you can clearly demonstrate that the trends are favorable. Case counts are going down, as you can see at the upper left. That also includes probable new cases that are not PCR confirmed, and our positivity rate is going down. And although our deaths went up with Delta, and you can see that on the right-hand side of the lower screenshot, they went up a little bit with Omicron, but not very much. And that reflects the milder nature of Omicron compared to the surge that we were seeing in late 2020. And you can see that sort of in the middle of the bottom part of the slide. So next slide, please. This is a picture that shows case burdens in Wisconsin's 72 counties, starting at the left, and the peak of our previously most challenging surge in November of 2020, with most of our counties in the red are having critically high levels of COVID-19. When we started to vaccinate people, there was a significant decrease in March of 2021. And around the July 4th of last year, we were really doing well. And then Delta hit us. And what you can see on the far right is the current case burden in Wisconsin counties. Every county in Wisconsin had a critically high case burden on average over the previous 2 weeks. These are updated every Wednesday at 3:30, and I do expect that we'll see some favorable trends in some of the counties. Next slide, please. So what's next with Omicron? Good news is Moderna received full approval for their mRNA vaccine. So we now have 2 fully approved vaccines in the US. We're also, at least 80% of people over the age of 5 in the US have received at least 1 dose of vaccine. Unfortunately, we're lagging the rest of the developed world, other than Russia, in terms of people that have completed their vaccine course. We're at 63.9%. And for boosted people, we're at running about 40%. So we're lagging most of Europe and the rest of the developed world. We know that vaccines and masks are still the best way to prevent infection, reduce the severity of infection by reducing your inoculum or the viral load that you're exposed to, and they minimize transmission. They're not perfect, but when you layer these strategies together, they're still the best tools in our toolbox. We do have the 2 oral medicines that are becoming more available now, and should be an added tool in our toolbox for people that can get them within 3 to 5 days of documented infection. Omicron appears to offer some immunity against new infections based on laboratory studies, but we only have 10 weeks of experience with it, so we really won't know whether so-called natural immunity or post-infectious immunity from Omicron is durable or very strong. We just don't know that yet. The good news is in the US, cases are decreasing dramatically across the entire country, every region, and about 48 of our states. Now, it is possible, maybe even likely, that after 2 years of dealing with COVID-19, we will shift from the pandemic phase to the endemic phase. What that means is we'll have a baseline low level of transmission. We'll have some predictability in terms of what we're dealing with, and we will maybe have seasonal peaks, but they won't be as dramatic as the surges we had before. The caveat here, though, is there's always a possibility of a new variant that emerges that escapes immune surveillance and may have significantly different biological properties. We saw that twice in the last 6 months with Delta, which we prematurely declared victory last May and June, and with Omicron, which supplanted Delta. Next slide, please. With that, I'll turn it over to Dr. Biller.
Hi, thank you so much for inviting me to be part of this presentation. Next slide. So we are all very familiar with the acute consequences of COVID, the illness, the hospitalizations. You know, if you watch the news over the last 2 years, you've seen a lot about that. But what became apparent, you know, 3 to 4 months after COVID came to the United States is that there was a group of people who had the illness, oftentimes had mild illness and were at home, but developed a variable cluster of symptoms that continued to plague them after their COVID-19. And it was very clear that this group was deviating from the rest of many other people who had the illness and recovered. The groups actually found each other on social media and began to call themselves the long haulers or long COVID. Excuse me. Last year, an official name of post-acute sequelae of COVID-19 or PASC was given as a name. And there is now another official name, which thankfully is a little bit easier to say, post-COVID conditions. It's estimated, looking at different countries around the world, that 10 to 30% of people who have COVID, again, I have to stress that it does not have to be people who were severe enough to be hospitalized. The bulk of our patients, 80% of our patients that we follow in our clinic have not been admitted to the hospital. And they will develop this prolonged group of symptoms after COVID infection. This can even happen to the 30% of people who have asymptomatic COVID. If you do the numbers, we estimate that there could be up to 240, even 300,000 people in Wisconsin who are affected by this troubling condition. Next slide, please. You know, COVID can affect lots of different organs. And what we see, we developed the post-COVID clinic, I should add, at the January of 2021. So we've just had our 1-year birthday. And a lot of themes came through. We saw people who had complaints in many different organ systems. But what's very clear is that the neurologic system is particularly part of post-COVID conditions, and especially the autonomic nervous system. And the autonomic nervous system is the part of the nervous system that is I call it the automatic system. So it's not voluntary movements, it's not thought, it's the part of the nervous system that keeps us alive when we go to sleep. Next slide, please. And here's one study that I'm showing, and there's many, many studies that verify the numbers that we've been talking about. This is a study that looked just at people who were outpatients, or the bulk of the people were outpatients, and it shows that at 6 months, 33% of individuals still had up to 3 symptoms that were distressing and affecting their quality of life. Next slide, please. There we go, see the numbers. And so in our experience, in a year of our clinic being up and running, we have had about 900 referrals. We've seen, well, actually over 900 referrals. We've seen almost 600 patients in our clinic. On average, people will be referred to 3 different specialists, specialty groups. Pulmonary, cardiology, and neuropsychology are our top 3. Most of our referrals are from within our healthcare system, but we have been taking some additional referrals from other symptoms. And as I said before, the overwhelming majority of these individuals were not hospitalized because of their COVID infection. Next slide, please. This is very interesting demographics. There is a predominance of women who seem to be referred into our clinic. There's also some racial differences. The bulk of our referrals are people who are white or Caucasian, and it's a much younger age skew compared to what the original pandemic numbers were for people becoming very ill and hospitalized. That age has come down with the Delta and the Omicron variants. Next slide, please. So what causes these symptoms to be persistent? We really don't know yet. There are several theories. One is that people have very minute amounts of virus still in the body that is present and causing the symptoms. Interestingly, on a patient-reported outcome through social media, 50% of people who have post-COVID conditions said that they improved after vaccination. One of the other theories is that the virus causes a very exuberant inflammatory response, which doesn't shut down, so that some of these are conditions like other inflammatory disorders that we see, inflammatory bowel disease, arthritis, but it tends to focus on the autonomic nervous system. There is the thought that there can be the development of auto antibodies or reactivation of other common viruses which can propagate inflammation in the body. The good news is that the NIH has realized that this can be that it is going to be a really significant issue that affects our society. The people who have these conditions need to seek a fair amount of health care, and so they have allotted $1.5 billion for research trying to figure out why this is occurring, and then once we know the why, we can try to come up with more effective treatments. Next slide, please. So my final thoughts are, I had hoped that we would open our clinic as a service to our community and take care of people who were in need of care, and that we would eventually put ourselves out of business. But this last surge has actually caused an increase in the number of referrals we're seeing to our post-COVID clinic. Most of the people that we see return to close to their pre-COVID health. Many don't get to completely their pre-COVID health. Some are so impaired that they will never return to that state of health, and some will not be able to return to work. So this could have an impact on our workforce. Of course, the best treatment for post-COVID conditions is to be vaccinated and not get COVID. So I always put in a message about the importance of COVID vaccination. And it is my hope that with more knowledge and as the fruits of research, that we will have a better understanding of what causes this condition, and then how we can really be more effective in treating these individuals. Thank you very much.
Dr. Biller, while I have you, before we
Yes.
go to Dr. Lehrmann, a question popped up I thought was pertinent to yours. Israel is one of the most vaccinated countries and as a result, the most studied. Can you comment on the recent research showing an overall increase in deaths due to heart issues and the possible relationship to the long-term effect of the vaccines?
So that's not exactly my area of expertise, but I think that's a complicated issue. It depends on what the state of health, and I don't know the incidence of coronary artery disease or other cardiac problems in Israel, and that would probably affect some of those outcome numbers. The vaccines, for full disclosure, my husband's a pediatric cardiologist, and he's on the American Academy of Pediatrics vaccine committee looking at the safety of vaccinations. And what they have found, particularly in children, is that especially adolescent boys can develop myocarditis, but it's very, very mild, and the overwhelming majority of them go back to complete health in a very short period of time. So I would say that there need to be much more robust investigation to link vaccination to cardiac deaths.
Okay. And one other quick question. Are there long COVID symptoms seen in children?
Yes. In fact, I've been asked to evaluate a 13-year-old. So I've been in close communication with pediatric pulmonary, and they have told me that they're starting to see increasing number of children who have long-lasting symptoms.
Thank you, Dr. Viller. Dr. Lehrmann.
Yes, good morning, and thank you for your interest in mental health and COVID's impact on mental health. Next slide, please. So COVID-19 has a negative impact on mental health for each of us. I think every one of you is feeling it in some way. But for those who have pre-existing disparities, they're disproportionately affecting mental health more in that group of people. Pandemic-related psychiatric symptoms are more prevalent in people with low-income households, for example. And also, I just want to call out that people with pre-existing mental illness are more prone to getting COVID-19, likely due to a link of them not being vaccinated as much and not being as connected to healthcare due to their pre-existing mental illness. Next slide, please. This is a slide that really, I think, emphasizes how this pandemic has affected every one of our mental health for each of us. There's high levels of stress with this. There's been a sense of a lack of control. Our whole world around us, we're feeling like the world is affecting us and we can't do much about this pandemic. Early in the pandemic, I think you'll remember that we couldn't even find toilet paper on the shelves. That's a natural reaction of people to try to get in control. And to buy toilet paper, for example, is one of the most basic developmental things that we go through potty training, believe it or not. And early in our development, the way to get in control is to achieve potty training. So I'm just saying this, that it was amazing to me that it even impacted us that way early on in the pandemic, with people buying supplies off the shelves, and especially focusing on toilet paper. Social isolation is having a negative impact on each of us. It's supposed to be physical distancing and not socially isolating, but it has led to social isolation for many of us. The unemployment that has come out of the pandemic, from the furloughs, from the decreased income that's affecting people, that obviously is affecting people's mental health. Homeschooling and the stress of having to school your kids while maintaining your employment has affected people's mental health. The fear of contracting a life-threatening illness or disease, that's what COVID is. And the fear of spreading that to your loved ones is something that impacts your level of anxiety. This has been a pandemic of loss. I think almost all of us on this call know somebody who has passed away from COVID. So we've lost loved ones. Many people have lost jobs. Many people have lost their financial security. Some people who are going to retire are now having to work longer because of the insecurities that this pandemic has caused. So there's been a lot of loss. Even working in your workplace, that's a loss. Having to work from home, that's social connectedness. Many of us have lost special events. We've had to cancel weddings and funerals and graduations. Our kids and many of us have lost sports through this, and our kids' varsity seasons in high school, for example. So this has been a pandemic of loss. I do want to call out that at MCW, we've opened a new grief clinic because of all the grief associated with the pandemic. And that's one of the things that we're trying to do to try to help our community. Next slide, please. So to be diagnosed with post-traumatic stress disorder, by definition, you have to face a life-threatening situation.
Renewed?
Well, this COVID has been life-threatening. So people are getting PTSD. Many of the frontline workers are somebody please mute your phone or your speaker. I'm getting some feedback. Anyways, some people, especially those working on the front lines or being who are facing the risk of getting COVID, are actually even coming down with post-traumatic stress disorder from facing this. And stress can trigger other anxiety disorders, including panic disorder and generalized anxiety disorder. And stress can exacerbate pre-existing mental illness, and we're seeing that. We're seeing increased depression associated with this pandemic. Since the pandemic started, 35% of the population has reported significant anxiety and depression. Previous to the pandemic, that was only 11%. So you can see it's tripled or quadrupled. Some studies even show it's quadrupled since the pandemic. So that's very concerning. We've also seen increased addiction. Alcohol consumption has increased greatly. Opiate use has increased greatly. And actually, this past year so far, we've already seen 100,000 deaths in the United States from accidental opiate overdoses. That's very concerning and has significantly increased. Next slide, please. According to a scientific journal, Lancet Psychiatry, 1/3 of patients who recover from COVID-19 later develop neuropsychiatric symptoms within 6 months. Topping the list was anxiety and depression. But also on that list was a brain fog, a decline in cognition ability that's seen in some patients with long COVID. Thus, one of the reasons why Dr. Biller commented that neuropsychology is being consulted, one of the 3 most common types of consultation for her patients. Not unusual to experience depression or anxiety when diagnosed with a chronic illness. So those who have long COVID have many times have also come down with depression and anxiety because they have this chronic illness. Next slide, please. So I think it's really important for you to know, as Dr. Biller said, first of all, I also strongly advocate for people to get immunized, because being immunized protects you from a life-threatening illness that also is very likely to create psychiatric sequelae. But I also want to call out that most mental health issues are treatable. Most mental illnesses are best treated with the combination of medication and talk therapy. There is a silver lining from this pandemic. Telemental health care is effectively delivered, and it actually is effective in treating mental illness, so it works. And that's been a silver lining, because we've had to pivot to that. And we're still at Froedtert MCW, about 90% of our outpatient mental health care is being delivered through telemedicine still. And I think our future is going to be such that a significant percentage, maybe up to 50% of our mental health care on the outpatient side will continue to be delivered with telemental health. I also want to call out that treatment takes time for people to respond. Most of our treatments do not have immediate effects. For example, antidepressant medications can take 2 to 4 weeks to even start working, and 6 to 8 weeks to really have their full effect. Psychotherapy takes time to work as well. So we need to be patient as we start initiating treatment, but treatment is necessary, and oftentimes, and people need to have access to that treatment. Next slide, please. Thank you.
Thank you, Dr. Lehrmann, Dr. Biller, and Dr. Raymond. I'm just going to jump up here to some of the questions that we've got and see if we can get some answers from the group here. So the first one is around the prevalence of home COVID tests, and are they impacting data much? And then a related question to that is, with home tests being sent out free that are not correct, I guess, if they get cold. Any comment on that?
Well, I'll start with, yes, if people had rapid antigen tests at home, I think that it may have lowered the case numbers, because if it was positive and people didn't feel like they needed to go to the hospital, they just isolated or quarantined for the 5 days. So yeah, but the fact is we had so many cases in the last 2 months that it probably didn't matter just in terms of public health policy. In terms of whether the tests are going to still be good, the ones the federal government is shipping out by USPS, there is a concern that if they are left out in sub-zero weather for a long period of time, that they might not be as sensitive. What I would say is they're still probably useful. We need to hear a little bit more about the concerns that people have voiced with real data. But what we know about these tests is they're quite sensitive and they're extremely specific. So if you get a positive test, you've got COVID. It's 99.9+% likely that you have COVID. So what I would say is that the tests, even if they were shipped in the cold, if you use them and you have a positive test, you know you have COVID. So there's still going to be some utility there.
Yeah, maybe this one is for you, Dr. Biller. Are you seeing a high rate of vaccinated people who have post-COVID conditions? And I know you talked a little bit about this in your presentation.
No, I'd say the overwhelming majority of people are people who were not vaccinated. Now, some of that is a little artifactual because initially when the clinic opened, vaccinations weren't readily available. So, you know, many people didn't even have access to them. And it even continues now that that more people who have continued symptoms are unvaccinated.
For fully vaccinated and boosted individuals trying to weigh the risks of travel, which COVID statistics for the possible destination are most relevant to look up? For example, is hospitalization rate not the most relevant metric because those numbers largely affect unvaccinated patients? So what recommendations would you provide there?
Well, for just like from the beginning of the pandemic, there's no one metric that matters. So I would say, look at the case burdens and the trajectory of whether the pandemic is shrinking or growing in the area that you plan to travel to. If you have comorbidities or you're unvaccinated and you're still going to travel, maybe you do want to look to see how full the hospitals are, because you would be more likely to require hospital services if you have a comorbidity. If you're older, you have diabetes, you're obese, or you're unvaccinated. But it's all the above. You really need to look at the simple metrics and not just hang your hat on a single metric.
Yeah. Dr. Lehrmann, I think this one's directed at you. Is there any use of art therapy in treating anxiety and depression associated with COVID?
Yes, most definitely. Though it's not widely utilized across the community from a provision perspective, I believe. We've certainly used it at the VA hospital, and it is effective in helping people with their self-esteem and also in helping them build self-confidence. And so I think it's something that can be very helpful. Unfortunately, it's not always reimbursed for. That's one of the major challenges of why we don't see it as widely provided as it perhaps should be.
And if someone, the best way to suggest to someone who may need mental health services, what's the best way to look into them?
So that's an incredibly important question. And in the workplace or even in the community, I think first of all is having a good relationship with your peers and friends. But I think we need to be direct. We need to say, you know, I noticed that, you know, lately you just, you know, haven't seemed like yourself. Is something going on? And I wonder if it might be helpful, you know, for you to get some help. Is there anything I can do, you know, and help refer somebody? There's actually an evidence-based approach actually towards suicide prevention called QPR, Question, Persuade, Refer. It's a very online, it's available online for some basic training. And it's not just in preventing suicide, although it certainly is evidence-based for that, but it's about how do you talk to somebody? And so how do you ask that question? How do you persuade them to go get help? So it's a nice online program that also helps towards that. But I think just being direct and showing that you care and notice somebody's not functioning like like they had been before, and or seen more down in the dumps, and just taking the time to show that you care and ask them directly how they're feeling and whether or not they've thought about getting help.
Yeah. Dr. Raymond, how do we know if the case rates are actually dropping if the symptoms are so mild that people might not be getting tested?
Well, first of all, not everybody has symptoms that are so mild that they don't know they're sick. It's actually a small percentage of the people. Mild symptoms usually are still significant symptoms, even with Omicron. What I would say is we look at a broad series of metrics. Nothing's changed with it in terms of people having a percentage of mild symptoms. So we had over 30,000 cases reported a couple of days, and we're down below 1,000 now. We were yesterday. So the magnitude of that change is so dramatic that you know the cases are going down. Hospitalizations also are going down. The deaths are starting to go down. And when you look at all of those together, you can be pretty confident that the circulating COVID in the community is going way down.
You know, Dr. Raymond, as long as we've been doing these webinars, it's always a very challenging back and forth on what you should consider when getting your children vaccinated. So the question here is, what's the rationale for vaccinating my 4-year-old when the long-term effects of vaccines are simply unknown at this point?
Well, let me start with the 4-year-olds. We don't have enough publicly available data to give a good answer to that question. That is the issue that the FDA is taking up now with their independent external advisory committee. So in terms of 6 months to 5-year-olds, I don't think we can answer that because the data aren't there. When you look at older kids, though, there are publicly available data that weigh the risks and the benefits of getting vaccinated versus being exposed to COVID-19 and getting infected. And part of the problem is we're having to make these decisions as parents based on incomplete data. Even for adolescents, we don't have the gift of time to be able to say, well, what happened a year later or two years later if somebody got infected with COVID or if they were vaccinated? We don't have that. But again, what I would say is that the weight of evidence for kids 5 and older still strongly favors getting vaccinated based on the people that care the most about the kids, your pediatricians and the professional societies that represent kids. We're going to need to really take a good look at the data that comes out for the 6 months to the 5-year-olds in the next couple of weeks. And Dr. Biller, since you're hearing a lot about kids too from your husband and from other folks, what else would you add?
I think we focus on concern about vaccination, but we don't always focus on concern about children having COVID and what are the long-term effects, as you've mentioned. There's also that very serious multi-system inflammatory disorder, which, you know, at times during the pandemic, children's hospitals have seen quite a number of very, very ill children. So I think when you are thinking about the risk and benefit, you have to also figure in what's the risk of your child having the infection.
It's okay. I'd like to add one thing too. I happen to be married to a pediatrician, and the one comment I want to make too that I think is an important factor that's not often discussed around this immunization, and that is the value for the society too. It's not just about your individual child. That of course you need to be concerned about their health, but there's also, if we don't reach herd immunity, there's greater risk for the rest of society and the rest of people as well. And I just wanted to call that factor out too.
Thank you. If I knew what these 2 words meant, I'd know who to direct the question to. But what's being done for people suffering for parosmia and anosmia?
Parosmia and anosmia, something Dr. Biller probably deals with every single day, is either the loss of your sense of smell and taste or a change that is unpleasant to you. My understanding is that if you can get rehabilitation for your sense of smell early from your ENT provider, that there is some likelihood that you can recover most or all of your sense of smell and taste. But if you don't do that early, it's difficult to restore that. And, Julie, you want to add to that?
Yeah, and I have to say we're very fortunate. My outpatient clinic is right next to ENT outpatient clinic, so we collaborate quite a bit. And we have 2 ENT specialists who specialize in, it's called rhinology, so the nose, and they have developed a really nice rehabilitation program, and we've seen people benefit from participating in that program.
Dr. Biller, I did want to ask a follow-up. How many people that come to your clinic have problems with their sense of smell, since we probably have spent more time talking about that than any of the other long-term consequences?
Just as a rough estimate, I would say maybe about 20%. Because I don't think people are being referred into post-COVID clinic if that's their only persistent symptom. So, oftentimes it's the breathing issues and the brain fog and chest discomfort that it really becomes a higher priority for people. And so that's what we're seeing. That's what I'm seeing in my clinic.
Another question here, as governors across the country are now dropping and eliminating mask mandates and other COVID restrictions, including in schools, even though the case rates in many cases are still higher when those restrictions are put in place, does this show a lack of true science behind masking and other restrictions?
I'll start by saying absolutely not. The problem is that there is so much noise about the politics and the personal beliefs of wearing masks and distancing and getting vaccinated. And that plays out orders of magnitude more significantly when you're talking about your kids than when you're talking about an adult. So it's so politicized. And let's face it, we're 2 years into the pandemic now. People are tired. They're tired of being told what to do. They're tired of feeling helpless. It's easy to believe some of the disinformation and misinformation about masks and other measures. And there are long-term impacts of kids being isolated or not being able to see each other's facial expressions, for example. I mean, I think those are real considerations. So we're trying to balance all of those, again, based on not a ton of long-term data. 2 years really isn't a long time. I think there will be people that write books about this pandemic for decades to come as we have the gift of time to look back and see what our real challenges were and what we could have done better. So it's such a politically charged issue about kids. Maybe I'm going to just put a pitch on. I know I say this all the time. Masks work. They work better when more people wear them in more situations and they wear them properly. If you're wearing a mask like a chin strap or a mouth guard or a necklace, they don't give you any protection. And part of the problem, especially in the US, is our culture that values individual liberty and freedom has made compliance with wearing masks the right way a political issue, a personal freedom issue. And so lots of people really haven't complied.
There's a longer question in here, but the gist of it is it getting harder to get vaccinations and boosters now? Relating to the experience that some folks have had, some of the clinics have now been, the public facing ones have been removed. Any sense of if it's more difficult now?
That's not what I've heard. There's still quite a bit of capacity and options for people. A lot of local pharmacies. We actually didn't really have a vaccination site for patients directly in the main Froedtert hospital, but the pharmacy has them. We call down there. They can oftentimes get people in, same day within an hour. So from my perspective, I think there's still quite a bit of, there's an easy ability for people to become vaccinated.
At this point, I don't see additional questions. I'd be happy if any of you have any closing thoughts. I'm going to just finish mine by thanking Dr. Lehrmann, Dr. Biller, and Dr. Raymond. This webinar series, which I think we envisioned lasting a shorter period of time, Dr. Raymond, than it has so far, I think has been an invaluable source of information for folks to take back to their business or back home to make their own personal decisions. And I appreciate the professionalism with which you've appeared, Dr. Raymond, over the last 2 years, and Dr. Biller and Dr. Lehrmann. And I just, continue to be challenged by people who approach this not with skepticism, but with a kind of fierce determination that we're out here to provide misleading information. So again, I appreciate the role that you're all playing, and if you have any final comments, I'm happy to entertain them.
Yeah, maybe I didn't hear you correctly, but it sounded like you said we were here to provide misleading information.
No, I didn't. You misheard me.
That is not why we're here.
I know that. I would say that you are here to provide information that we can all take home to make our own decisions on, and I so deeply appreciate the professionalism that you all bring to that.
Thanks, Tim. Thank you.
I just would like to say that I hope we can all pull together even more against the virus. I feel like it ends up being politicized and it's people against people, but it really needs to be all of us against the virus. And people on the front lines are getting very exhausted. We're having to serve a lot of the frontline people from a mental health perspective. We need this pandemic to settle down and become an endemic, as Dr. Raymond, I think, said it's heading towards, and I hope that it is. But we need to work together to get there. So thank you.
And I would just continue on that theme that America is based on people having personal freedoms, but we're also based on having been very strong as a nation, and people, as they factor into their personal decisions, should think about what their decision is doing for the rest of their community. And we need to start thinking about community. And I'm still hopeful that the post-COVID clinic will one day be out of business because we will have implemented such good procedures with vaccination, masking, distancing, and more knowledge on how we can battle this virus, and that we all go back to what is a more normal life style. So that's my hope.
Well, again, thank you all, and we'll end on that note. Dr. Biller, here's to putting you out of business.
Great. We all have the same goal.
Well, thank you all. Enjoy the rest of your day.
Thank you.